Show me right from wrong. Give me light, make me strong. I know the road is long. Make me strong.
Amio. Very important. Uh, let's hope you don't meet one day. Afraid, okay? Crumbles. Guy is Dr. Dylan Narayan Singh, an oncologist, trained in of this that we all don't want to think about, and we're all going to think we're not going to get cancer. Today is a big one, ladies and gentlemen. We're talking about cancer. We try to open the lines early tonight. What I would really like is to have people who have cancers, who've had treatment for cancers, call in and tell us about their experiences with their treatment, things they liked, they didn't like, and how they think services could be better in Trinidad. It'll be great to get feedback. You know, people like Dr. Narayan Singh also need the feedback. He tells me, by the way, he's also Director of Health Services for Northwest, Port of Spain region. So, you know, here's a chance to give some direct feedback to a prison administration too. I don't think he likes administration, though, Dr. Narayan Singh. Welcome once again to Dr. In-House. We really appreciate you coming back because you had joined us once. You joined me once before, didn't you?
2 years ago.
Years ago?
Yeah, time flies, huh?
Wow. What have you been doing all this time?
Vancouver.
What were you doing? Psychology or
yes.
administration?
No,
I hope it wasn't administration.
No, I actually did radiation oncology fellowship in Preston.
You getting to spend much of your time now, I hope, in clinical work, not just tied into administrative work.
Well, it's a mix of both. I actually do some clinic. Try to
So perhaps I could explain to the audience that, you know, this guy looks a bit young, but the problem is when doctors achieve a certain seniority in the service, they are pushed into administration. Fortunately, I left much younger age, so I didn't have to get involved in all. I couldn't deal with public service. I'm just not tough. I'm just not strong enough a person to deal with. But Dr. Narayan Singh, so at his level now, despite his love for treating patients and sick people, you know, and planning and carrying out treatment and organization at patient level, they get pushed into administrative work because they have to spend a fair amount of their time running services and managing their staff and writing letters and dealing with ministers and things that really not something they don't particularly like. But unfortunately, you know, you might ask yourself, well, this doctor, he's this big consultant and thing, and you hardly ever see him when you go to the hospital. But in fact, the higher level doctors that you don't see are probably stuck in meetings all the time, talking stupidness with all kind of other people, you know. So, anyway, back to you, Dr. I'm glad you get to still spend time with patients, which I imagine is what you probably like to do. So you say you were doing a fellowship in Vancouver. That's different. So Canadian healthcare was thought, we used to think of it as the best in the world. Is it really the best healthcare system in the world?
Well, I think it's a pretty decent healthcare system. It looks at it's a public-based system, so that everybody just sort of very similar to us, so that a lot of people actually join the so you actually join the public service. And unlike our system, there's not very much of private practice, especially in the British Columbia system. So everything is all based on.
So there's no private doctors. You just go to the public government hospitals.
Well, there are, but the majority of people, really irrespective of social status, race, so will join the public service and will get the same.
So rich people, poor people going to the government hospital.
Going to the government hospital, yes.
Okay, and what's the standard like there? Is it?
So no, it's a pretty good standard of care. You'd probably find that there are, so in order to have a system like that, what would happen is that, I mean, patients will have some degree of insurance coverage, but you will find that everybody gets appropriated care based on the need. They're very good in terms of looking at cost-benefit analysis to determine what would be the best test, the best treatment that should be available to patients. And you know, sometimes we complain about waiting times for exams, example, MRIs or operating times. Well, in the Canadian system, you know, our waiting times aren't too badly compared to them.
Do you have to have a long waiting time, say, for an MRI?
Well, you may have a long waiting time. I mean, there's some things that may be urgent and you will therefore, but there's some things like MRI.
In Britain, I remember in the NHS, there were long waiting times for like coronary angiograms, but once we thought that the patient needed it urgently, we just circumvented the system.
Right.
So they gave the doctors the leeway to bring up everything.
And that's the same thing in the system. So if you do have something rather urgent,
they get it done. They deal with it when they have to be. Yeah, well, I imagine it was a different world, though, working in a first world setting compared to a third world setting.
Yeah, and I think, well, one of the nice reassuring things is that perhaps it's good that a lot of the say, for example, radiation planning that we do for breast and head and neck, would similar to what we be doing down here. Of course, because everybody's very specialized, maybe there might be a few differences in the way the management maybe, but by and large, there was great similarity in how patients were managed.
Really? So you say broadly we're doing the same thing.
So in broadly, I think we have really good, dedicated health professionals. Sometimes you realize that actually maybe some of the chemotherapy drugs, we actually had a lot more of it that were freely available here in our service. And probably you had to have what we would either call compassionate in Canada. They may say, well, this drug doesn't have a very good cost-effective benefit, therefore it may not be readily available. Those were actually good learning points. You know, it doesn't mean that because something very new comes out, means that, you know, it's actually going to be
exactly, which I think is a problem. They're rational about how they spend their money. They give the patient the best value that I ain't really sure, but the cancer patients in Port of Spain area anyway, I think relatively good treatment. I mean, a lot better than the heart patients. You know, I don't know if that's just the impression I have. Okay, so tonight, Dr. Narayan Singh is going to be teaching us a bit about cancer, some basic things about cancer. I wanted to so remember we open the lines early from 8:45. I really like to get people who have cancer, if you're brave enough to come and talk about it on the TV. You know, happy to listen to your stories. I like to learn about it. why do I want to know about cancer? Because I'm wondering if I might get myself. So what's my chance of getting cancer though?
Well,
I'm 59. I'm almost 60, going on 60 years old.
right. So, well, I think that they're very, just
Pretend
very,
you don't know anything about me other than that. I'm a Trinidadian male, 59 years old.
right. So, 59-year-old, well, you look very good for 59.
Thanks.
But we know that we expect maybe within the next 5 to 10 years that cancer will overtake heart disease and stroke as the most common cause of death in Trinidad and Tobago.
So I'm probably going to die from a cancer then. That's what you're saying. Chances are,
well,
statistically, I might well die from a cancer.
Statistically, yes. And what we think is not that you probably wouldn't, the average person probably wouldn't develop heart disease and or diabetes or so, but these are now very chronic conditions that people live with, and now that we find that people are living much older, well controlled on their heart disease and their diabetes by and large. As you get much older, you're probably going to develop a cancer.
So I might end up having both heart disease and cancer. I've got some wonderful things to look forward to.
And really, the major cancers really are lung cancer, prostate, breast, colorectal, and probably looking at pancreatic also. But those tend to be the big cancers that we're looking at. And quite interestingly, actually, when you look at breast, you look at prostate, you look at colorectal, which really are the big ones. They're actually all ones that you could actually pick up relatively, and cervical cancer, sorry, are ones that you could pick up very easily on screening.
Right.
So
maybe you could teach us a bit about screening. I think our audience should know a bit about screening, but I think the more we know, the better. Maybe we could, if you want, we could talk about that tonight. That is how to kind of pick up cancers early. And that's the time these guys could actually treat you and prevent progression to big time cancer problem. So essentially, my take on it is that most of us, I tell my patients this, I don't know if it's still thought to be, most of us actually have cancers inside of us already at any one time. And I tell them, I probably have several little cancers, but they're all locked up by my immune system, and they can't develop into full-blown cancers. And my job is to try to live in such a way to keep them locked up so they don't flourish. Here's my plan. Okay, so can you guys show my dinner slide tonight? The slide of my dinner. So here's what I do. I have this phone. Take pictures. Like it's taking pictures of all the food that they eat. Put it out on Instagram. So here's my dinner tonight that I just had. Okay, it's called tabbouleh. So I'm vegan. People think vegan food is boring, and this food tasted really good. To the point that when it starts to taste too good, it becomes a problem in itself. It's probably keep much. I can't stop eating very easily. My problem. Once food starts to taste good, I just keep eating. So this is something you could eat a whole lot of, actually. So what is it? Tabbouleh. This is not probably real tabbouleh. So a real Syrian Lebanese person would probably look at this and say, "What you calling that tabbouleh?" But it essentially is a salad made of finely chopped parsley and tomato. Basic ingredients. What you saw, there was a lot of cucumber, mint, and you could use bulgur wheat. But I think what my wife used there was Thai red rice, which she said isn't very expensive. It's not a whole lot more than ordinary rice. Normally, I discourage eating rice. I tell my patients don't eat no rice, but say what? The red rice is fairly healthy. Not that unhealthy. So you have the basic ingredients. Once again, just say parsley is very healthy food. A lot of flavonoid, antioxidant stuff in it, probably anti-cancer. I don't know if Dr. Narain subscribes to all of this food business and cancer. We'll find out. We'll find out what his thoughts on food and cancer are later, because I plan to give him a quiz and find out how healthy he is. He doesn't know about that yet. So the parsley is really good. The tomato, I think, is good for my prostate. I don't care what they say. I eat the tomato to keep my prostate away from it. The cucumber, good, lots of fiber in it. The chive, it's an allium. Allium also, that thing you saw on the picture there had a lot of onion as well. Onion isn't really part of this dish, but my wife throws in everything she has last minute. So the chive and onion, the alliums are good. These things also may be anti-cancer, just anti-inflammatory or anti-inflammaging things, you know. And then there's the bulgur wheat. So you could use stuff like quinoa, or you could use any kind of heavy grain with, you know, talking like I could cook, right? But I've never cooked anything in my whole life. I just tell you what my wife told me. Just so you marinate this stuff in lemon juice, olive oil, and ton loads of garlic. You just add ton loads of garlic to whatever you eat. That's my take on it. Salt and black pepper. And the thing tastes really good, to the point where I can't stop eating it. So what are the downsides to that? Now, for the downsides to that dinner was there's not a lot of protein, I suppose, in it. So I had a small amount of dal soup afterwards, a dal-based soup or lentil, peas-based soup, you know. To me, that's good enough for me. It also tastes really good, by the way. Downside, again, is that there's a fair amount of salt in that food. For me, I think my salt intake is relatively low. My potassium intake is very high from all the fruit and vegetables I eat, but my sodium intake is probably generally low, so I don't mind killing the salt sometimes. So I overate on that salad, that tabbouleh salad. Probably took in a little too much sodium for one meal, but it's not something I do that often. So, other downsides. Oh yeah, the lemon have dental sensitivity. So sometimes the gum margins tend to burn a bit. So I use an antacid tablet in my mouth. So it's not much downsides. It's a lot of fiber. Several useful, what I call phytochemicals, which I keep talking about on this program every single night I come here. Eat lots of plants because they have good things. And the plants have little medicines in them. Not big, heavy medicines like Dr. Narain when they give you, but they have little bits of little medicines, and all of them add up. The more of them you take into your system, the more they sort of reprogram your system and keep you away from getting cancer and stupidness like that, and heart problems and things. So I'd advise everybody to check out tabbouleh, experiment with it, and eventually you get good at it, and probably find you don't need a whole lot of the other things you're eating. We take a short break. That was my dinner for tonight. Every night I come here, I'm going to be telling you about my dinner. Right? My dinner, we take a short break, and then we're going to be returning to Doctor in the House with Dr. Dylan Narain Singh, very important cancer specialist, who I'm very sorry to say may well be treating one of us one day, either you or me. So soon be back, ladies and gentlemen, after this commercial break. Okay.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
Keep refreshed with Oasis Premium Purified Water. Now available in more thirst-quenching options. 330 ml, 600 ml, 1.5 liter, and 5 liters. Choose the size that fits you best. Grab one today.
For the everyday lowest prices on all grocery items, trust Low Cost Supermarket for the widest variety of quality products at low prices. Freshly picked fruits and vegetables, healthy products for your well-being, high quality meat cuts, and a warm and friendly service. Low Cost Supermarket, Sun and Main Road, Cunupia.
Welcome back, ladies and gentlemen, to Doctor in the House. And I, of course, am your annoying host, Dr. Feroz Omadeen. I'm interviewing Dr. Dylan Narain Singh, who is an oncologist, a cancer specialist. Dylan, welcome again. Thanks very much for being here. I'm hoping that we have lots of people who are going to use your expertise and bring in. And I'd like to hear about cancers, because I think I'm probably going to get one day. And you might have to treat me, so I guess so.
Well, you know, actually, sorry, but you know, a lot of times, I guess as we live older and we do tests for more, and, you know, people go for CT scans for other things. We pick up small lesions. So sometimes you pick up something in the thyroid, which we do more commonly now. You pick up something in the kidney, and you know, people go for screening, and sometimes now we may be picking up things that, you know, may not have given you any problems anyway. You probably would have died from something else. But the fact that we now pick them up means that we sort of almost obligated to do something about them. And many times that we have all these changes occur in cells every day. And as you rightly said, you know, the immune system, these really acts to prevent these cells from, you know, beginning to continue to multiply and develop the potential to become invasive. And that's really what we worry about.
Right. So it's a question of, cancer is a sort of, I guess you could think part of life then, but it's a part of life that the body often is able to control pretty well. And it's when it really breaks out of control that you all have to get involved. You'll get a clinically evident cancer, and it starts to really make the patient feel sick, and you have to then...
So we have cells that undergo what we would call mutations every day. And the body has a way in which it's able to deal with that. And, you know, that's why as you get older, after years and years, you know, there's always the risk that you could, you know, that you could have a cancer. And it probably goes back to the basic principle of screening.
So the mutations, sorry to interrupt, the mutations get more common as you get older?
Well, you get mutations, and cells, a lot of times as you get older, the ability for cells to repair these mutations, that's the damage to DNA, becomes a lot more difficult as you age.
This is why older people are the ones who tend to get the cancers.
And
we still see them in young people.
Right. So it's part of the aging process. And you find, so therefore it goes back to the basic principle of screening. And one of the basic principles with screening is that for some cancers, the natural history is that the cell will become abnormal. So there's a mutation, and it may take sometimes months or years, and then those cells could then develop the potential to be able to spread. And really, it's only when a cell develops the potential to spread that kind of therefore cause problems by spreading to other organs. So with screening, we hope to actually catch those cells before they've developed the potential to spread. And if we've done that, then we can actually almost effect a cure because they haven't developed the ability to spread.
So you were just telling me here, well, what actually causes cancer in the sense that I understand that there are mutations that happen in our genes. We're not born with these, we're born with the good genes, but the genes undergo spontaneous mutations, and this leads to the breakaway cells just becoming uncontrollable cancers. But you were saying to me earlier that there are specific things that sort of encourage it, so causes, and what in modern life causes your cells to become mutated into cancer cells?
Well, I think, so there are different things. So we know that there are what you call genetic causes for cancer. And so let's use an example like breast cancer. So I think we probably all very familiar with Angelina Jolie, who had the BRCA, better known as the BRCA mutation. So there are some mutations that you're born with. And we know that because of those mutations or those genetic defects, you're going to be very susceptible for getting cancers. And really what those mutations do is they prevent the cell from being able to repair damage that's done. We think about a third of cancers, and it varies from population to population, may have some very big genetic component to it. About a third of cancers actually will probably have environmental factors that would account for them. So actually the commonest cancer worldwide is really skin cancer. It doesn't really, we don't actually put skin cancer in the same category as breast and lung and cervix and so. But the commonest cause is skin cancer, and skin cancer, by and large, really is caused by exposure to sunlight. And then, of course, another third of cancers are really due to what we now associate with lifestyle, modifiable gene, things that can change. So we know that diet, exercise, and so these things can therefore lead to, because they cause obesity, can lead to the cancer. And we know that, say, for example, to use maybe breast cancer or endometrial cancer, obesity may be related to an increase in the amount of estrogens in the body. And that increased estrogen can either result in breast cancer, can cause endometrial cancer. We know that anecdotally that people who eat a very high fiber diet may probably be at a lower risk of developing colorectal cancer. And we talk about this refined Western diet usually being associated with colorectal cancer. So we know that there are a lot of modifiable things that we could do. And it's all
so you're saying I could probably reduce my risk of cancer in general 1/3 just by living very healthily,
right?
Which is what I'm trying hard to do.
And it's not just really cancer in itself. I always tell all my patients, when they ask me what type of diet to eat, well, I tell them, well, they should really, everybody in the family should work together towards, it should really be a hearty diet. Because actually, right now, heart disease really is the #1 killer in Trinidad. So your modification of your diet towards a heart-healthy diet
is almost the same as the anti-cancer diets.
It's exactly, yes. Yeah, so it's relatively, really no different. So, and sometimes what tends to happen is that, we just cook for one person in the family. The one person makes the lifestyle change, but really it should be the lifestyle change for everybody. And even if you're not looking at it just with respect to cancer, you should look at it with respect to diabetes and heart disease. Because now that we have, better medications and people live longer, it means these chronic illnesses last longer.
Yeah, and it's inflammatory aging, so I think I think it will affect all of it. Look, before we get, because I probably spent too much of this time on this program talking about thing on lifestyle and so on. We're probably going to be discussing your own eating habits later on. Why don't you tell us a bit about what you what do you do from day to day with your patients? You involved in so you say you treat solid tumors, which is like breast and
prostate, lung, colon.
Right. So you treat the whole gamut, the majority of the common
right. So
cancers you treat then. That's a very broad
it's a
field.
very,
I mean, it must be a lot you have to be reading all the time to keep up with this. It must be a tough field to be in, and if it's a lot
well, yeah. So in the British side of the Atlantic, you have what you call clinical oncologists. So clinical oncologists treat with chemotherapy solid tumors. So that means we treat everything except hematological disorders, such as like your leukemias and your lymphomas, and then we treat with radiation. On the American side of the Atlantic, you're either a radiation oncologist, so you treat radiation, or you're a medical oncologist, you treat everything with chemotherapy. So what you'd probably find now is that you'd find that because the field is so ever expanding, compared to maybe 10 years ago, it's probably very difficult for somebody to keep up with everything that's happening in solid tumors, chemotherapy, and radiation. In fact, the field in itself is starting to become more and more subspecialized.
Okay, so let's say, but you basically treating all different, everybody who comes in with cancers, and so let's say somebody comes with a breast cancer. What sort of work you will be doing then with that tumor to try to?
So when somebody comes in with a breast cancer, so one thing when somebody comes into an oncologist is they already have a diagnosis of cancer. So to make a diagnosis of cancer, really, in all intents and purposes, you need a biopsy. And really, a biopsy is really the only way that you can tell whether something is a cancer. And really, a biopsy means you take a piece of it, and the pathologist looks at it under a microscope and can tell you that it's a cancer. And that's very, very important, because for all the different cancers, treatment has gone so much further that we can now say, for example, for lung cancer, we can now say, okay, well, there are different types of lung cancer. And even for each different type of lung cancer, we can look at different things that have gone wrong with the cell and determine whether your treatment based on that. So, you know, it's not to say that, okay, well, we see something on your lung and, well, everybody's going to get the same treatment. So you come with a diagnosis. The first thing that an oncologist would probably very much want to know is what's the stage of the cancer. And the stage tells you how far is this cancer. And the stage is usually given on from a 1 to 4. 1 meaning it's relatively early, 4 meaning that it's spread or metastasized. So if, for example, a patient comes in, you may find that your doctor may order a CT scan, they may order x-rays, they may order the test, maybe a PET scan or a bone scan, depending on the type of cancer that it is. And then we also look at other things. We look to see if you have any medical problems, and we look at something called performance status. And performance status is very important. So performance status is just a very simple scale. It goes from 0 to 4. And 0 means that you're doing your normal daily activities, and 4 means that you spend more than half your day in bed. And that sort of gives us a guide into how we're going to manage you. And once we've got the staging, we look through your medical, see if you've got problems, look at your performance status. Then we're able to take for each different subtype. So say, for example, you've got breast cancer. We can then say, okay, well, how do we go about managing this? So if it's, say, for example, early stage, you may have already had an operation done by your surgeon, or sometimes some people come with the diagnosis, and then we discuss, well, if, for example, there's a lump in the breast and the lump is quite large, we may say, okay, well, you can have the breast taken out, or some patients may want to have their breast conserved. So we may say, okay, let's go and attempt to shrink this lump. So we may offer chemotherapy. And therefore,
so it's not the surgeon who makes the decisions. It's you all advise the patient.
Well, that's actually a very good point. So it's brought up. So the whole management is really based on what we call a multidisciplinary approach. So it's the surgeon along with the oncologist and the patient at the center. So they may have some people who may come in with a pretty large lump. And you may say, well, you know what? Everybody else in my family has had mastectomy, so I'm not going to conserve this breast. I want a mastectomy done. And if that's the patient's preference, then they may go on to have a mastectomy. They may have somebody who may come in and say, I really do want to have breast conservation. And if that's the case, then what we will do is we'll give chemotherapy up front in order to be able to shrink the lump to allow them. It's a sort of a dynamic between everybody trying to come up with what's the best approach for the patient.
The first thing is you stage how far it's gone. You type the tumor to see, it's not just a breast cancer, it's what kind of breast cancer it is and what type of treatment is. And then you look at the patient and you look at the performance index, you call it, performance status, and you decide and you look at their own preferences, what kind of treatment they prefer. And you have to add all these things together and then decide what your plan of treatment is for that point.
Right.
That sounds like a lot of hard work. I mean, if you want to do it well.
If you want to do it well. And of course, stage is very important. So sometimes you'd find, patients may say, okay, well, let's use another example. Let's say colon cancer. So let's say, for example, you had a blood test, you realized you were anemic, you had a series of tests done and showed that you had a colon cancer and you had your colon cancer removed. And everything looked fine. You did a CT scan, it didn't show any spread anywhere else. A lot of times you may say, well, you know what, if the surgeon took everything out and my CT scan looks fine, why do I need any further treatment? And it brings in the concept of something called adjuvant treatment. And adjuvant treatment really means that you're treating disease that you cannot see, but the treatment is based on the probability that there might be something there. So I would tell my patients, it's not obia, but it's, it's really a bit of science. And we look at that probability. So and that holds true for a lot of cancers. So when we treat adjuvantly, we're weighing your probability that this cancer can recur.
Okay.
And if
you're not actually treating, you've taken out a cancer, and you're trying to decide it's possible there's still some in the body of that patient, and you're going to give drugs based on that's what you call adjuvant.
Right. So adjuvant
chemo
and radiation. And if that risk is very high, then we think that we are, the benefit is there and we're justified to give it. If that risk is very low, then we would weigh the benefit to see whether or not it's worth it. And sometimes the risk may be so low and the side effects from treatment may be high that we would say, well, it's probably better that we know that there's a small risk that the cancer could come back, but we would probably not want to give anything and we would just follow you up because your risk is so low. And as you said, it comes back to two very big basic areas in terms of adjuvant treatment: chemotherapy and radiation. So chemotherapy is drugs, and drugs are something you can give either intravenously or through tablets. But the one big thing about drugs is they all get into your bloodstream, and therefore they can go throughout your entire body. It means, therefore, they are working theoretically on cells that might be anywhere from the top of your head to the bottom of your feet. But it also means that they have potential side effects that can happen anywhere from the top of your head to the bottom of your feet. So if we think that your risk is probably high enough for recurrence throughout the body, we would therefore recommend chemotherapy. If we think the risk for recurrence is high within the area where the cancer was, if you had a large breast cancer and you had a mastectomy and we think that there's a risk that could come back there, or you had a rectal tumor that we took out and we think there's a risk that it may reoccur there, then what we do is we offer you radiation treatment. So radiation is a very localized treatment just to the area where the cancer was. And the thing with radiation is the side effects would be limited to that area.
Right. So the two central cornerstones of the treatment are chemotherapy and radiotherapy. And apart from surgical removal of a cancer, you do chemo and radiotherapy.
Right. And
so Well, what exactly, you know, okay, a lot of doctors, including myself, we kind of get a bit, uh, we don't know a lot about chemotherapy, modern chemotherapy. I mean, we trained a little bit in it in medical school, you know, but it's a sort of nebulous area to us. First, you want to tell the patient, tell me, what do these drugs actually do? They sound like pretty bad drugs.
Well, I think the chemotherapy drugs, so there are some drugs that do have quite significant side effects.
Well, what do they actually do to the cancer?
So what they do is that, chemotherapy works on, chemotherapy works on a general principle that cancer cells grow faster than normal cells. So what they do is they work at different areas of the cell to prevent this, to stop the cell from growing, or literally to kill the cell.
Right.
Of course, what happens is it can also affect normal cells. But we know because cancer cells grow so much quicker than normal cells, we can get rid of more cancer cells than normal cells, and the normal cells can repopulate themselves.
Right.
So that's the basic principle of chemotherapy.
So the areas in your body that grow fast might, like, maybe your hair and your stomach, and so the areas that are growing fast might be the ones that the drug might also bother.
Right.
But they can recover quickly because they're growing fast.
Right. And what you know is that each different drug is very specific in the organ that it can affect. But there's also the new concept of what we call targeted therapy or targeted agents. And what targeted therapy or targeted agents do is that what be able to therefore look at the cell in terms of a molecule, and that something has gone wrong. And we're actually able to target what's going wrong in the DNA of the cell. And as a result of that, it means therefore the side effect profile has totally changed with respect to the drugs that we give. And it also means that, well, because we know that we're targeting something that's gone wrong, the chances that we may have potential success is probably better. So that's the way in which cancer...
There are ways to channel your drugs only to the tumor cells, and that's what you're saying, away from the normal...
yes.
Okay.
So I mean, it still has side effects on other organs, but so it means therefore that patients may now find that after they've been given their diagnosis of cancer, the further tests are now done on the tissue, and those further tests actually now be able to determine our medical management of the patients. And we do actually have a few of the targeted treatments available in the public service. Actually, one drug that's so commonplace now is a drug called Herceptin. Herceptin is an antibody to a mutation that happens on the HER2 gene, and therefore if patients test positive for it in the breast cancer, we can actually use Herceptin for treatment.
So it's an antibody that specifically targets the tumor cells itself.
Yeah.
So I notice a lot of my patients, they don't refer to that as chemotherapy. They refer to that as a different sort of therapy,
so
immunotherapy or something.
Yeah, immunotherapy or targeted treatment.
Okay. So how expensive are these drugs, now, these chemotherapy and immunotherapy drugs?
Well, they all vary in price. You tend to find that the newer drugs themselves probably tend to be a lot more expensive than some of the older drugs. That being said, some of the older drugs still are the basic standard regimen that we use. So, for example, in breast cancer, yes, we have things like Herceptin, but generally the old drugs like adriamycin and cyclophosphamide and Taxol still tend to be very basic drugs that work effectively. And even with all the big studies that have been done, they still remain the backbone of treatment.
So in Canada, they're still using them also, right? Just like here.
In Canada, they still use them.
So the backbone of our treatment here is not a whole lot different from what you're doing in Canada.
No.
That's interesting.
And I think probably the most important thing, one of the big things with chemotherapy is understanding that there are potential side effects. And what we do is we've actually, where the advances have come, is trying to be able to address those side effects more adequately. So people usually associate chemotherapy with nausea and vomiting. So now
They're
we have,
scared of I mean, I'm scared of it. The chemotherapy, how bad is it really?
well, they have drugs that can cause quite significant nausea and vomiting, but now we have newer drugs, some of them available in public service, that actually work quite well with nausea and vomiting. And actually, I could tell you a lot of patients actually complain sometimes of the constipation that might be associated with some of these anti-nausea medication, but may go through their chemotherapy without having the effect of nausea and vomiting.
Nausea and vomiting, I think I could cope with. I mean, with some nausea and vomiting, it's there forever. But what else is there to look forward to if I have to get chemotherapy?
Well, it depends. It depends on the type of cancer. Some people who have colon cancer may come and think, well, okay, everybody always talks about with chemotherapy that you're going to get hair loss,
Yeah.
and expect quite severe nausea and vomiting. And actually, for colorectal cancer, the drugs actually don't cause hair loss. They don't usually cause hair loss, and not usually associated with nausea and vomiting, to the point that we routinely don't even give anti-nausea medications with it. Whereas you may find for commonly like breast cancer, the drugs that we use in breast cancer will in fact probably cause hair loss, may be associated with nausea, and you think probably one of the big things we always used to worry about was that it could affect your white blood cells. That was always really the big problem we had. So sometimes your white blood cells get very low and you become at risk for infection. You get very, very sick. So we have drugs now that we can use that can help to push your white blood cells up. And therefore that has made a very, very big impact on management and treatment with cancer.
Okay. So I get the part about the nausea, vomiting, and I guess infections and hair, but will the chemotherapy just make me feel sick? I mean, will I feel terrible? I don't want to feel terrible. I could take some nausea and vomiting.
Well,
I don't mind my hair dropping off, but I don't want to feel awful.
Well, it depends, it's another question everybody asks, and I always tell everybody, well, it depends on the type of cancer, the stage of cancer, and the drugs that you're using. And even with the same set of drugs, people do differently. Some people may find they may feel tired. Some people get changes in their taste in their mouth, and some people do well enough that they're able to go to work and so even while on chemotherapy. It's really, really a huge gamut. And of course, to be very fair, I mean, there's some regimens that are quite toxic, that you really just feel quite unwell having them.
So I guess this is where you have to sit down and counsel the patient through it, and also they have to be prepared to take the chances too. They don't know how they're going to respond until they actually tried it.
Right, and I think that's the most important thing. Sometimes you'll never know how you'll feel, so sometimes you go right through all these side effects, and you'll have some patients who will get everything, and some patients who will probably not get, most of them.
So if I do end up having to take chemotherapy one day, I shouldn't look forward to it with dread. Sit down and talk it through with you first, and it may not be that bad as I think. But
yeah, and I think one of the things would really be that when you develop your side effects with respect to the chemotherapy, it's important to let your oncologist know, so that if, say, for example, you get a side effect, so you find you get your chemotherapy this session and you find that you really do have quite a bit of nausea, then at the next time what we'll do is we'll try to see if there's something else that we could add on with to help with nausea. If it is, say, for example, you find that you're getting, say, very much darkening and peeling of your hands and feet, we could see how we can modify your chemotherapy dose to be able to help with that.
Does the age of the patient, make a big factor in it? Because if I get a cancer now, I might be more inclined to accept chemotherapy. But if I'm like 75 years old, I'll probably be pretty mashed up and weak by then. I don't know if I really want to put myself through chemotherapy. So is it a big factor for your planning?
Well, age is actually a factor that we take into account because, well, one, we know that as you get older, your reserve, your ability, your whole physiology, the whole makeup of your body is a little bit different to when you're much younger. And we also know that You also have a lot of other medical problems. Maybe about 10, 15 years ago, well, this predates me a bit, but you would generally have read that by the time you were 70, most people would probably be very, very cautious in terms of giving chemotherapy. Actually now, what we do is we look at your age, but we look at your performance status, we look at your other morbidities. And, you know, so there's really no, we don't actually say now that there's a definite age. And I'd probably use the example, I mean, in Vancouver, you know, people go into their 80s, 90s, carrying on with life as normal. So to not treat somebody in their 70s, saying that they probably have a limited life expectancy, would probably not be the way to go. But what is important? So, I mean, you know, and I see it many times in my office, you have people who come in their 50s and 60s and, you know, don't look in very good shape at all. And then they have people who come in their 70s. And, you know, you definitely know that, you know, that they probably have a decent life expectancy ahead of them. Of course, we do tailor the regimen and we do take into account the age. But it doesn't mean that we're not going to say, well, okay, you know, you're 75, so we're not going to do something about it.
Yeah. Well, we have the same kind of dilemma in heart disease, where there's some older people who really are strong and healthy, enjoying their life, and some of them working hard.
Yeah.
And working hard for their family and stuff. So we under more pressure to be more aggressive in those people. But for us, it's well, for things like stenting and bypass surgery and so on, aggressive treatments, there's also a risk. There's expense too. And these aren't provided by the government service. So we have the additional factor of expense. So does your patient have to cover the costs of these chemotherapy drugs?
Well, there are really two ways in which patients could get access to care. So they can come through the public service, or they can go through the private service. You go through the private, you pay for your treatment. In the public service, it's provided free of charge. Sometimes,
so where are the private care centers then?
So you'd have, say, for example, at you'll have in Medical Associates, you'd have at Southern Medical, you'd have Brian Lara Cancer Treatment Center, and you have one or two other places around.
Right, and where are the public centers that treat cancer?
So, well, we have one public center that all pediatric cancers are centralized to, and that's at Mount Hope.
Right.
Then you have, well, the National Radiotherapy Center in St. James that does everything. Port of Spain General Hospital does hematology. You have
that's leukemias.
Leukemias.
Right.
You have Grandi. They do solid tumors and hematology. And then you have San Fernando, where they have chemotherapy for solid tumors and hematology. And then Tobago has some chemotherapy also.
Right. So the same sort of stuff work in all the areas, or you'll
So no. So it means, therefore, that what happens is that each of the regional health authorities has their own...
I forgot, yes, the regional health
authorities. Yeah. Each of the regional health authorities has their own oncology service.
I used to work in the service in the days before the RHs, so that's... it sounds strange, but I still don't understand these RHs. Okay, well, we're going to take a short commercial break. I'm hoping that people ring in and talk to us about cancer, because everybody with cancer has a story to tell. Huh? And by hearing people's stories that we learn, so if any of you are prepared to share your story about cancer, you'll hear what Dr. Narayan Singh has to say about it. So please bring in. We'll open the lines in a short while after this commercial break that we'll take on Doctor in the House.
Sheikh Leisha Limited, the leading manufacturers of vermicelli, split peas powder, and grease-proof paper. We also manufacture a variety of paper and plastic bags. We have bags for French fries, sandwiches, popcorn, supermarkets, stores, and much more. Whatever your needs, trust Sheikh Leisha Limited for quality products. Sheikh Leisha Limited, Warrenville, Cunupia, telephone 665-3336. Oh.
I'm a cool kid, you're a cool kid, we are cool kids, are you a cool kid? Every day I want it, I need to drink lots of it, full of fruit, vitamin C, give me lots of it. My imagination is growing and so am I. I'm getting big, so give me fruit of cool kids, it's so juicy, so I could touch the sky.
Become a cool kid now by visiting www.fruiticoolkids.com.
High blood pressure is as dangerous as an overpumped balloon. Measuring your blood pressure every day can save you from risk of high blood pressure. MicroLife fully automatic upper arm blood pressure monitor with stroke risk detection. MicroLife AFib screens for atrial fibrillation while taking your blood pressure. High blood pressure and atrial fibrillation are both considered controllable risk factors for stroke. If AFib is present during blood pressure measurement, the AFib icon is displayed flashing at the end of the triple measurement. Once 3 measurements are complete, the measurement data are shown on the display. MicroLife, a partner for people, for life.
Ladies and gentlemen, welcome back to Doctor in the House. I'm Dr. Feroz Omardeen, and tonight my guest is Dr. Dylan Narain Singh, a cancer specialist, and they're called oncologists. And Dylan is oncologist working with both the government in the St. James National Radiotherapy Center, they call it NRC, but it's called Radiotherapy Center. But from what he says, it treats cancers in all forms. They have a center that service, take care of all forms of cancer treatment for most of the tumor types. And then you also work in the private sector, but I think in Southeast Asian.
Yeah, Southern Medical.
Okay. Well, thanks for coming, and thanks
Thank you very much for having me.
Yeah, it would be. I think I learned quite a bit from the talk you just gave us. I'm hoping that people call in and talk to us about cancers a bit, but. In the meantime, you talked about chemotherapy. What about radiation therapy now?
So
I'm a bit suspicious about radiation therapy.
Well, radiation therapy really, so radiation therapy itself has sometimes got a very bad name. And, people usually would, look at radiotherapy and, expect that they get all these burns and all these complications associated with radiation.
Yeah, and X-ray is supposed to cause cancer, and X-ray is supposed to have terrible effects and kill people. I always tell people I don't like too much X-rays, and I discourage them from doing CAT scans because I say, look how much radiation they have in this CAT scan. Okay, we'll come back to this. We have a call from Trin City. Hello there, Trin City.
Hi, good evening.
Hi, good evening.
Good evening, Dr. Narain.
Hi, good evening.
Just calling to find out, start to radiation treatment.
Right.
Why do fistulas form? And how often do they form? And what type of cancers that are being treated, you get fistulas after the radiation treatment?
Okay, that's actually a very good question. So, the radiation is really the use of X-rays in order to be able to treat a cancer. And a fistula is actually a connection between two organs. Right? So it means, therefore, that you can have two hollow organs, and when a hole forms between them, you can have a communication. So if I were to use an example, so you could get, if you say, for example, we're treating a cervical cancer, and the bladder is right next to the cervix, you could get a hole between the bladder and the vagina, or sometimes between the rectum and the vagina.
Right.
Right, and that's called a fistula. Now, so fistulas can occur as a side effect as a result of radiation. And sometimes what happens is that when you have a cancer that's invaded into an organ, and that cancer gets treated and it breaks down, then what happens is that you can actually get a connection happening between the bladder and the vagina, for example. You could get that happening. Sometimes you could get fistulas formed in other areas. So it is a complication that's associated with radiation treatment.
Between the devil and the deep blue sea, because either you have a cancer between your uterus, between your vagina and your rectum, or you break it down and you have a fistula.
Yeah.
It's pretty terrible for a woman to have a fistula.
Oh, yeah, no, so
because stool will be coming out the vagina.
Yeah, so you could have that happening. Yeah, so it tends to happen in some of the cancers. They can happen.
Thank goodness we men, boy, I think real tough. Women get it too with the prostate.
So it can happen. So it can happen anywhere that you have organs that could communicate.
So they do radiation therapy for prostate cancers?
Yes, yes. So you can do radiotherapy for prostate. So there are actually two big different types of radiotherapy that you could do for prostate cancer. One, you could use what we call external beam radiotherapy, conventional treatment from the outside, or we could use brachytherapy, where we actually put in radioactive seeds in the prostate. So that's another way in which you. So really, going back to it, external beam radiation, or what we call radiotherapy, really is very much giving radiation from the outside, and with newer technology. So what would happen now in 2017 is, before you're really treated with radiation and with any great extent, we'll do a CT scan for you in a very particular position. And what we'll do is we'll actually draw any organs that we would like to treat. We draw in where we would like to avoid. And then we actually see how we can actually get this X-ray beam sort of wrap around where we would like to, and minimize the dose to the other areas. In the olden days, when we didn't really have all that technology, then almost everything in the area got treated. So that's where the
got radiated.
Yeah.
So you have special ways of controlling the radiation to only go to the spot that you, or mostly go to the spot.
Mostly go to the area. So we can increase the probability that we're treating where we want and decrease the dose to the other areas.
So how accurate is the Trinidadian service compared to the service in Vancouver? You think that the external beam treatment is, because I imagine it takes a fair amount of money and heavy equipment to get this kind of thing going. Trinidad has this sort of money to do it?
Well, we have some of the really expensive equipment, and we actually have some of the really good techniques that we use with something called IMRT, where we're actually able to bend the beam around.
Yeah, that's interesting. IMRT, I have to learn about that.
Yeah, it stands for intensity modulated radiotherapy.
Okay, I'll check that out on Wikipedia tonight. Aruka on the phone. Good night there, Aruka. Hello.
Yes, good day.
Hello, good evening.
Hi, good night.
Good night.
Hi, good night.
Good night. Thanks for calling.
Okay, I missed some of the earlier parts of the program. I just wanted to find out two questions.
Sure.
What's the survival rate of gastric cancer? And what's the most effective treatment for it up to date?
Survival rate for what cancer?
Pancreatic.
Oh, pancreatic cancer. Okay. All right. That's a tough guy you're asking. Yeah.
Right.
Okay. So, you said a second question, or you want to know just specifically about pancreatic cancer? Okay. We'll definitely answer your question. We'll work on that. But let's just take a call from Maraval in the meantime. Take a call from Maraval in the meantime. Maraval, good night.
Yes, yeah. What?
Hi, good evening.
Yeah. How do you know if you're having colon cancer? What sort of a system? How your system would function?
Right. Okay, that might be an easier one for Dr. Narain to begin with. Yeah. Thanks for that question. How can I, for instance, know if I have colon? Why should I suspect that I'm having colon cancer?
Well, I could probably start off that by saying the ideal way we should find this out is before you even have a problem or a symptom. So you should be perfectly fine. The minute you actually have something that's going wrong with your bowel or your stool, we probably don't want that to happen. So we would usually say, and I always tell my patients, I said, you know, one of the nice things is that by the time you reach the age of 50, you should have a colonoscopy. But in terms of symptoms that we're looking at, we've been looking at, do you have problems with change in your bowel habits?
Constipation,
diarrhea. So you're not going as you would normally have done. Do you have, you know, do you find that you're having bleeding in the stool area? Sometimes some people may find that they may begin to lose weight. Sometimes you go just for a routine blood test and you may be anemic. So those are things that could...
Yeah, because you're losing iron in the blood.
Yeah.
And so iron deficiency, anemia, and without a good explanation would be, right. So you saying you should screen the colonoscopy. I had one done when I was 50 as a screening, so I guess
so you're due for another one.
Another one? No.
Yes.
Okay, I hate that thing. Anyway, it's much better than getting colon cancer. Okay, San Fernando on the line. Hello there, San Fernando.
Hello.
Yes, hi.
Hello.
Good night, doctors.
Hi, good evening.
Explain to me what is multiple myeloma and what are the treatments for it, please?
Sure.
Thank you.
Sure.
Okay.
Thanks for that question, myeloma.
All right. So multiple myeloma is what we would call a hematological malignancy. So it's actually a disorder of the blood system. And there's something called plasma cells. And plasma cells are a type of white blood cells, very simply. And sometimes those plasma cells can behave very naughty. So multiple myeloma means, therefore, that these cells have actually begun to multiply. And usually what would happen is they would usually affect the bone. And because they affect the bone in many places, that's how we get the name multiple myeloma. Now, these cells also produce other things. They produce proteins, and they also affect the bone marrow. So therefore, what they do is, in affecting the bone marrow, they replace some of the normal cells. So as a result of that, it can affect the bone, which is commonly how most people will present.
You mean pain in the bones?
So you might get pain in the bone. Sometimes you go and you pick something up and you get a fracture. And we do tests and we realize, well, okay. So that's one. Sometimes you'd find for older people, they may actually get things like anemia. They may get recurrent infections. So these are things that can affect patients who have multiple myeloma. By and large, the treatment for multiple myeloma is systemic, so it will involve some form of chemotherapy. It could be something as simple as taking tablets and steroids to sometimes actually intravenous chemotherapy agents, or we have some forms of targeted therapy. If it is a patient has multiple myeloma and say has an area that's giving quite significant pain, we can actually radiate that area. You know that people with multiple myeloma also at a very high risk of developing high calcium levels. So we also give them drugs to be able to reduce the calcium levels.
So the specialized type of, it's not a leukemia, you don't call it a leukemia, although it's a tumor of white cells, really.
Right. So the
You don't call
plasma,
it,
right?
it's plasma cells.
Plasmas. Yeah.
And they behave different from leukemias, and the treatment is a bit different.
Yeah.
I have some family who had myeloma in New York City. He used to work with a hospital, right? And he got the state paid for bone marrow transplant in this guy. It was a long time, about 15 years ago, and they told him he'd probably live for about 8 to 10 years with the bone marrow transplant. He still, apparently it worked, and he's cured of it.
Yeah. So that's,
but it would have costed $1 million to the American taxpayer, according to the expenses, you know. Do not have the kind of money to spend like this for people with bone marrow transplant.
well, so we do have a bone marrow service, and so and multiple myeloma itself is treated by a hematologist. So what the hematologist could do is, if you're a potential candidate for bone marrow, they'd give you certain chemotherapy, and then most patients would probably have to access their bone marrow transplant outside of Trinidad.
But the majority of people don't really need that, I take it. I mean,
well, it really depends on how advanced it is. It depends on your age or your comorbidities and stuff.
Yeah. Because I mean, I used to treat myeloma in Jamaica, I remember, and patients seem to do pretty well, many of them. I guess that myeloma, every cancer, I think, is different. Every myeloma patient is different, and you have to decide how, you know, some of them you hardly want to treat at all, if I remember correctly. In very mild cases, you might.
You may not, and it depends. And it depends on the age, because you have a lot of other competing interests at that age.
On their performance status, you said. If you're 80 years old and in bed from heart disease, and you can't, I guess, amputated leg from diabetes, and it really doesn't make much sense. We have a call from Tacarigua. Hello, Tacarigua. Thank you for calling.
Yeah, hold on.
Hi, good evening.
Good evening, Dr. Narayan Singh.
Yes.
What I want to find out, if you have an enlarged prostate, and before you get to the stage of a cancer, which I hopefully I don't want to, I think I read somewhere where you can use a steam treatment to shrink that prostate. Could you enlighten me if there's any truth in that?
All right, so that's a very interesting question. So it's always really good to differentiate between what's an enlarged prostate and what's cancer of the prostate. So they're actually two different things. And enlarged prostate really is what we call, so you can have an enlarged prostate and cancer in the prostate. You can have a normal sized prostate and cancer in it. An enlarged prostate happens as you get older due to years and years of having lots of testosterone. And prostate cancer in itself is very much a little different to that. Now, what we do know is with prostate cancer, what would happen is whether you have an enlarged prostate, you have a normal sized prostate, we still ask you to make sure and get your PSA. So there's a little controversy over screening, but we do tell you to get your PSA done.
I don't test mine at all. Nobody. But you
and
think
do a rectal examination to check.
So you would advise me to go and get my PSA done?
I would definitely advise
really?
that.
And a rectal examination?
And a rectal examination.
Gosh.
So you can, I mean, we can, in the treatment of prostate cancer, we can actually decrease the size, we actually can prevent, we manipulate the hormones. But BPH, which is the
benign enlargement,
and prostate cancer, two different. They a lot of times they coexist because older gentlemen get prostate cancer as well as the other.
So many or most of us, if we get old enough, will probably have benign enlargement, I guess.
Benign enlargement, right. And there was already.
That's a big problem in itself.
And there was actually a very nice study that was done by the U.S. Armed Forces, which showed that by age 80, about 80% of men would probably have some form of prostate cancer anyway.
Right, great. Yeah. Which is exactly why if I'm going to get this thing anyway, you know. Okay, we have a call from West Moorings. Hello there, West Moorings.
Hi, good evening.
Hi, good evening.
Yes. I have a question for Dr. Narayan Singh.
Yes.
I wanted to find out your thoughts on calorie restriction or intermittent fasting, both in cancer prevention and as a therapeutic tool in treating cancer, especially in young, well patients like breast cancer patients who are caught early and are in good physical condition.
Okay. Thanks for that unusual question.
Yeah, so that's actually an interesting question. The calorie restriction. So there's a bit of so maybe but there's, I wouldn't want to say, I don't know how to phrase it properly, but there's sometimes a perception that that cancer cells feed on sugar, and that therefore we need to so a lot of times what people do is they try to restrict sugar in that because the perceived perception is that the cancer cells will feed on sugar. And we know that we need sugar for the entire body itself to carry out its normal daily functions. So if it is that you're particularly doing calorie restriction simply for the form of trying to prevent a cancer from coming on, or if you have cancer, the treatment of it may not be the right approach. Now, if it is that you're doing something as part of lifestyle change in terms of diet modification, so that, let's say, for example, you are overweight or obese and you say, okay, well, I'm going to monitor my calories and therefore try to reduce my calorie intake, then that's probably a fair approach done in the proper way. And I've always said that to my patients that, you know, even if you're overweight or so, when you make changes, you need to make the changes so that they are they become part of your normal lifestyle, and it's something that you could carry on with. So even if you lose a pound or two a month, nothing more than that, you give it a year, it have lost 12 to 25 pounds. But if you could do that with something that's sustainable, then that's actually a good way to go. But I do probably know where the question is coming from, because it's and I've heard it in Vancouver, I've heard it here, heard it many different places about either pH and sugars and meats being associated with cancer cells being rapidly dividing.
But I imagine, especially if you have an underweight patient on chemotherapy, you have to be a little cautious about, you have to make sure they have adequate nutrition, and you have to be careful what
you really don't want to very much
starve the whole patient.
Starve the patient, because then what happens, you start breaking down proteins, then your something called your albumin levels drop, and therefore the drugs no longer bind to the albumin, and they could actually become a lot more toxic, and then the body can't heal itself.
Yeah. But I have to say though, most of my patients are overweight anyway. Okay. We have Sawa on the phone, or Sanwan, as I want to say. Sawa, good night. Thanks for calling. You still there?
Yeah. Hello?
Hi, good evening.
Yeah. Good afternoon. I am 75 years of age. I did a colonoscopy about 5 years ago, and everything came out okay. It was recommended that I use a little magnesia to go off softly and so on. But recently, I started getting had stools again. Went to the doctor, and he sent me for a stool test. I did, and all the three tests I did, 3 different days, and it came out like everything was cleared, and I didn't have any blood in the stool.
Right.
Right.
Still have this stool coming off kind of lumpy like. Should I do another test?
Another colonoscopy?
Yeah.
When was
5 years ago.
5 years ago.
5 years.
Okay, that's an interesting question.
So
thanks for that question.
Yeah, that's a very interesting question. Probably not very much through my domain. The usual recommendation is that without symptoms, a colonoscopy, we usually do what we would call the fecal occult blood test. So
Right, which he did. That's
which
three,
he did,
three days in a row. He checked
and
for
was
the blood in his
negative.
swim, negative.
Negative. So, I mean, at 75, there are different reasons why you may get hard stool. Of course, I mean, you'd always wonder the back of your head whether or not it's related to colon cancer. I mean, there are other reasons. As you get a bit older, you do get changes in your bowel habits. Sometimes even something as simple as, you know, thyroid functions change. You find that your bowel habits also change. I would usually recommend, I mean, if it is that you're really quite concerned, you could probably go and see a gastroenterologist, and they can probably assess you to see, you know, what may be, if there are any other contributing factors to this. And sometimes quite a number of tumors are actually just there at the rectum. So sometimes something as simple as just a rectal examination is actually quite good.
So what you're saying is, it's difficult to assess this one on the phone. You wouldn't rush to doing colonoscopy again. You basically get a good doctor. It would be nice to get a gastroenterologist, but in Trinidad you can't get these guys. There are few of them, and they're very hard to see in Trinidad. That's my take on gastroenterologists. They're all good, but they're difficult to get appointments with and so on.
I think this guy, his physician, actually started off along a very good track. Doing the fecal occult blood.
So your doctor seems to know what they're doing. Better stick to them.
Yeah, but probably if it's not thing, probably really see a gastroenterologist.
Okay, so we have a call from Baratario. Good night, dear Baratario.
Good night.
Hi, good evening.
Good night, doctor.
Hi, good evening. Hi.
Good evening. Congrats on an excellent program you have there.
Thank you.
I would like to ask Dr. Narayan Singh. I understand that recently there was some reports in some medical journals about fish oil. I use approximately 3 grams of fish oil a day. I understand that reports, they are claiming that fish oil increases the risk of prostate cancer in general. Can you comment on this?
Right. So I know that there have been various articles that have come out looking at weighing the benefits of fish oil and other contributors from diet with respect to cancer. So what I could say is just that generally what we would probably right, and you also have to weigh, and this is probably where Dr. Omar Dean comes in.
A bit too, don't forget that.
So this is where Dr. Omar Dean comes in, because you have to now weigh the competing benefits between fish oil for cardiovascular disease as well as for its possible, implication with possible cancers. Now,
so it may actually increase your risk of prostate cancer.
So we probably will have to have other studies done, because sometimes we tend not to go with just with one. So we would probably want to see if we have more in order to be able to do that. So sometimes we would say until we really have like a lot of evidence and we've actually come out to see a good group. But you also have to weigh your cardiovascular risk, and just to deviate just 1 second. So it probably goes off to maybe the question over this proverbial glass of wine. In that we know that alcohol, each unit actually increases your risk of cancer, but we know it to a certain extent it decreases your risk of cancer, of heart disease.
The first two,
right. So we usually say for men the first 2 is fine for the day, and we'll just say 1 for women, and then after that the risk really just doesn't add up and the curve goes the other way.
Okay, so can't answer your question about fish oils here. There are questions about it, and he's going to sit on the fence until he gets more research. He's not prepared to give you an answer on that one just yet, on the fish oils. Curep, we have Curep on the phone. Hello there.
Hi,
Hello.
good night, doctor.
Hi, good
night,
evening.
good night.
Okay, my question is a continuation of the one from West Mooring, where the lady asked about sugars, cancers feeding on sugars.
Right.
But there's a new craze now where people are saying that they're taking apple cider vinegar because they say the more acidic the blood is, where the body is, the cancer thrives. So they're taking the apple cider vinegar to lower that pH. Could you elaborate on that for me, please?
Right. So that's another, and you're perfectly right. Maybe that's that's the word I was probably looking for. So probably more a bit of a craze. So we know that that was popped up. You know, it's people looking at the pH and attempting to change the pH either by apple cider vinegar or lemon and water or so. So how I usually would put it is this way. So if you were to take cancer cells and you put them in a dish in the lab, and you were to change the pH and make it more acidic, they'd die. If you take your normal cells and you put it in the in a petri dish and you put it in the lab and you make it more acidic, they will also die. What the body does is that if you try to change the pH, the body is going to use different mechanisms to restore the pH to a very narrow range. So when you try to change the pH, what you're actually doing is you're actually giving your body a little bit more work in order to be able to try to bring the pH back to where it should be. So so actually changing the pH isn't actually going to probably affect the cancer as much as it's probably going to affect your normal metabolism.
So you're not a fan of apple cider vinegar?
No. So I mean, if you're using it as you know, part of so using it as part of as part of your salad or so. But to say that you're actually going to, you know,
a lot of my patients they swear by apple cider vinegar for their heart disease. They think it's really helped them a lot, and they have it mixed with honey and also each one of them. And for some of them, I mean, I'm not going to stop them, but whatever, if it does help you, which Dylan isn't a big fan of it, but if it does help you, I don't think by changing the pH. You know, people have this idea about changing pH, alkalinizing your body, and some of them actually buy this alkalinized water. They pay a lot of money for it, and they drink it, or ionized water. I don't know. This is what, to me, you know, that sort of thing just don't work. It's more distracting you from real potential treatment. We have a Freeport. We have a caller from Freeport. That would be our last call. Sorry, because we have to answer the guy about pancreatic cancer.
Hello,
Hi there, Freeport.
Hi, good evening.
Good night.
Yeah. Good night.
Yeah, good night, doctor.
Good evening. Hi.
Well, I have two, not questions, but one is a question. That is, I would like to know a little bit about vincristine and vinblastine, how effective they are in treatment of bone cancer. And the second thing is that my experience with the prostate is that I had a PSA done in March month, and it was reading 1.7. And I had to take out my prostate in June month because it was so large. And the only thing that really told me about the size of the prostate was an ultrasound because it measured the size. And I noticed like doctors don't use the ultrasound as a means of, finding out about the prostate. I'll listen on it. Thank you.
Thanks very much for that. Very interesting statement there. So that I think he's emphasizing that the cancer and the size of the prostate is two different things. Yeah, so it's really the PSA could be fine, but the prostate.
So right, and that's why we always combine the PSA with the digital rectal exam, and that's why we also say we do the PSA yearly. So sometimes if your PSA is markedly elevated, well, we have a red flag raised there. But what is more important is probably not the absolute PSA at one point in time, but what happens to that PSA over time. And this gentleman is actually quite correct and probably answers a question that somebody asked before, in that as you get older, your prostate enlarges, and that gives you people get symptoms. It's, you know, what you see in the movies where gentlemen take a little longer when you go to the washroom, you take longer to pee. You sometimes have to go very quickly to the washroom, go to the washroom regularly, get up at night. And that's usually due to the prostate itself becoming enlarged. Now, the different ways in which you could tell whether the prostate is enlarged, one way is you could actually do a rectal examination and feel. And as you rightly said, you could do a rectal an ultrasound and measure the size of the prostate, and you could also measure something called the median lobe. And what they would do is they would actually go measure the size of your prostate, ask you to fill up your bladder, pee, and then see how much urine you've actually voided, and then measure that afterwards. And if there's quite significant, sometimes what the urologist may do is may give you either something to relax the muscle. If it's quite severe, they may actually chip away at part of the prostate in order to allow you to
and all this might be independent of whether it is PSA caused by cancer or anything.
Right.
Okay. Dylan, we promised the guy about
the pancreatic cancer.
This is the most difficult one.
So pancreatic, it's a very, very interesting question, and pancreatic cancer in itself. So we know that at presently pancreatic cancer, it's one of those cancers that usually tends to present relatively late. And about, half the patients who present with pancreatic cancer wouldn't be alive within the first year of having their diagnosis. We think our statistics in Trinidad, in the next few years, we would probably have better statistics because we've started better statistic recording now. But we do generally know that we're seeing, on average, more pancreatic cancer cases. And what makes pancreatic cancer difficult is that a lot of times by the time it's actually taken up, because you present with problems like jaundice or
by the time it's a real big cancer, it has to get pretty big before it and cause real trouble before you even know it's there.
Yeah, and by the time you actually pick it up, it's either not resectable, which is the ideal, case we would like it to. And a lot of people
you can't take it out. The surgeons can't take it out.
Right. Then you'll end up either having to have chemotherapy or and radiation to try to shrink it, or for the majority of patients, it would have presented already, where it's spread to other areas. So it becomes what we call palliative. And that was one thing we didn't talk about, and maybe another conversation
that
another time.
Is the most important thing, the palliative treatment for advanced cancer. I wish I could get doctors to come, but I don't even know if the audience, this is the problem. I have to figure things that the audience is interested in, and if I come and talk about palliative care on this program, I think the patients who actually have cancer are very interested in it.
Well, palliative care in itself is not only cancer.
Yeah.
It involves HIV and stage renal disease. Yeah. But it's very, very important because it means that we're looking at how do we make your quality of life good and addresses questions.
Like pain.
Like pain.
If I have cancer and I'm dying from cancer, the only thing I really want to be assured of is pain control. I mean, otherwise I don't particularly. Okay, we've run out of time. So, I was going to give you a quiz on how healthy your eating habits were to prevent cancer. I have 25 foods here that prevent cancer. Not all of them I believe in or eat, but so Dr. Narain, I'm afraid we'll get away tonight. We won't have time to give him his quiz and see how healthy he really is. But we have to wrap up the program, and thanks very much to Dr. Dylan Narain.
Well, thank you very much. Thank you very much for having me.
And we're hoping to have you back again, maybe next year. On behalf of Dr. Narain, myself, the station, and our sponsors, thanks very much, ladies and gentlemen, for tuning in to Doctor in the House. See you next week.
Milkana butter, an experience for your taste buds. Smooth, flavor-filled, rich, velvety butter. Milkana butter for cakes, pastries, pies, or just place it in any of your favorite dishes and add that rich buttery taste to all your meals. Why choose another? Look for the butter with flavor, the butter with the creamy richness in taste. Milkana butter. Distributed by NM Ghani 2003 Limited, #1 in